Good evening and welcome back to the Lipid Panel. My name is Dr. Merle Myerson, and I am co-chair of the programming for the Lipid Panel, working alongside with Dr. Guy Mintz and FNLA liaison Amanda Hicks. The Lipid Panel was conceived to be a lipid clinic conference on a national scale. For those lucky enough to have in-house colleagues, Lipid Clinic Conference is a great way to debrief after a busy clinic, to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies and come together with colleagues. For the rest of us who feel like we are on lipid islands, conferences like this remind you that you are not alone. NLA is with you. If you have cases that you want to be presented at future conferences, please email Mandy at ahicks@lipid.org with your suggestions. So in this series, we will review common presentations of rare diseases, atypical presentations of common conditions, and sometimes even common presentations of common conditions. And we will try to cover as many important clinical topics every lipid specialist needs to know. This series is meant to be a monthly coming together of rising stars like NLA lipid scholars and early career lipid specialists with more experienced colleagues. So we have one more session in June, and then back in September, we'll start up again. And reminder, we do offer CME credit. So going ahead, I'd like to introduce our panelist. So our case presenter is Dr. Zhengran Wang. He is a resident, actually completed his residency training in internal medicine at UC Riverside School of Medicine in June of 2023, and is currently a fellow with the UCI Integrative Cardiology Fellowship. Now, Dr. Nathan Wong is a cardiovascular epidemiologist known to many of us, author of many articles and guidelines. He's a specialist in preventive cardiology and professor and director, the Heart Disease Prevention Program, Division of Cardiology at UC Irvine. He has joint appointments in epidemiology at UCLA and UC Irvine, and population health and disease prevention at UC Irvine. He holds both an MPH and PhD in epidemiology from Yale University. And he's been an investigator, collaborator on many NIH studies, author of many papers, and really just an expert in the field for decades. We really appreciate him being part of this tonight. So I'm going to turn it over. We will start presenting the case.
All right. Hello, everyone. Thank you, Dr. Myers, for the kind introduction. Yeah, my name is Zhengran Wang. As she mentioned, I'm the current integrative cardiology, this little innovative program at UC Irvine. I'm the fellow. Without further ado, let me introduce you to the cases. We have two cases for you. This is the first one. It's a secondary prevention case. So we have a 52-year-old male, Asian Indian ancestry, got admitted with, for STEMI and received a stent to LAD, and he also had some mild stenosis and the non-cooperative vessels and got treated medically. He has diabetes on metformin. He smokes 1 pack per week, and he's not interested in quitting at this time. He has a history of mild hypertension, hyperlipidemia, and is working on lifestyle interventions such as low-fat diet and low alcohol intake, and he is not on lipid therapy at the time of the MI. And his brother at age 48 had a stent and passed away at age 60. And on his review of systems, he had chronic fatigue, constipation, and dry skin. Next page. Okay, so on the admission to the hospital, his exam was not remarkable. So here are his vitals, as you see. I will not read it, so you can see it out here. He didn't have any corneal arcus, xantholateral tendons, and xanthomas. Those examination findings related to hyperlipidemia. His cholesterol, the lipid panel, was detailed as below. And on discharge, he was started on atorvastatin 80, lisinopril 10, Plavix 75, and enteric-coated aspirin 81. He was also not started on beta blocker because of slow heart rate.
let me just interrupt you guys there. Can we just go back to the initial slide, please? So I guess, Nathan, you have a 52-year-old Asian male with certain risk factors. So even if he walked into your clinic as a diabetic and a smoker, hypertension, I mean, how would you and Dr. Myerson look at his risk factors?
Well, he certainly, already has presented with the STEMI, right? And he has multiple risk factors. So, most of us would consider him to be very high risk. And perhaps if we can go to slide 11, if you don't mind, I just to review with the audience. Slide 11. Okay, yeah. So remember our 2018 guidelines, for the first time really got us thinking about the fact that we can't put everyone with ASCVD right into one bucket. So they define this very high risk status on the basis of having multiple major events or one major event and multiple high risk conditions, right? So this person has a recent ACS, but also has diabetes as well as hypertension. And I believe he also has persistently elevated LDL. So he would be defined as a very high risk patient, right? And I think what's interesting that you also have to consider is that he is of Asian Indian ancestry, right? And according to our guidelines, also this is identified as a risk enhancing factor. So we have to recognize that point, and we'll get to I want you to move on here, but what's interesting, maybe we could just go to slide 13 real fast. So here, the Lipid Association of India, which I've been pretty involved with for a few years, identifies someone with actually diabetes and ASCVD and multiple risk factors as an extreme risk patient. And they actually suggest even lower targets of an LDL of 30 milligram per deciliter or less. And our most recent guidelines was published in Journal of Clinical Lipidology quite recently. I might point out also, if we go to the prior slide, slide 12, that our US recommendations are somewhat, less strict, right? So, even this consensus guideline would, put a very high risk patient as recommended, non-statin therapy if the LDL is still 55 or higher, despite high intensity or maximally tolerated statins. So, I think we have to think about, given this patient's ethnicity and multiple risk factors, right? How low should we really go in terms of the LDL? So anyway, that was kind of a long-winded answer, but I'll let you proceed.
All right, so let's go back to slide number 1. So Merle, before he gets to the MI, and he comes into your office with just 52-year-old male and that risk profile, what would you do differently in terms of treatment or assessment for him?
Right. So
prior to MI.
A couple things come up for me. And by the way, I had not yet seen the Asian Indian goals for LDL. I have been using the 2020 endocrine guidelines, which for a very high risk, which I think we can all agree this gentleman is, my LDL has got to be down by 55, if not lower. So the other thing is his family history, gosh, a brother at age 48 and another, he's pretty young. He has diabetes, the smoking. So, I would do further testing, check in LP(a), get to work on the smoking as well. He does refuse to quit. Maybe we can help him at least cut back. So, yeah, this patient really jumps out at me as needing very aggressive control of his risk factors, very aggressive care.
I think that's great. I mean, I have my rule of thumb is diabetics suffer from diabetes, but they die from MI and stroke. And I mean, this is someone that should have been put on statin therapy the minute he said, "Hi, glad to meet you." All right, so Dr. Wang, why don't you
Exactly.
continue? Yeah.
And I might just add a comment that, it really relates to the whole issue that we have to change a paradigm and thinking of diabetes as much more than a actually blood sugar problem, right? It's a cardiovascular problem, and data we've published shows that if you're at target for not only A1C but also blood pressure and LDL cholesterol, that your risks are 60% or so lower than if you're not at target for any of those factors. So very important that this patient has diabetes and we manage all these risks.
Great. I think that's a great point. So, Dr. Wang, why don't you start from the end of the second slide, which is a physical exam, and take us into slide 3.
Sounds good. So we talked about the discharge medications, right? Torvastatin, lisinopril, clopidogrel, enteric-coated aspirin, and beta blocker was not prescribed because of low heart rate. Let's move on to the next slide. So the patient was doing well, fortunately, 2 weeks after discharge. But the only thing was that he had muscle ache in his extremities. So came back to the office. Statin was stopped for 2 weeks, and then his muscle cramps went away, and restarted on torvastatin at 40 milligrams. And in 2 weeks, symptoms came back, unfortunately, and but although they were milder, so he was able to continue the dose of 40 milligram. And after 4 weeks passed, here are his new set of lipid panels, as you can see below. Okay, so here is our first question, and I just want to say that a lot of these questions are not just kind of one right answer. They're meant to be for discussion, so there could be multiple right answers. So where would you like to see his LDL, and what would you do first? So would you want to discontinue his statin and change the lower intensity, or do you want to consider PCSK9 inhibitor as monotherapy? Or do you want to do maybe ezetimibe as monotherapy, or perhaps request repeat labs and then remain on the current dose of statin for now?
So Merle, why don't you take that one in terms
Sure.
of treatment?
So I think the first thing, and I don't have the previous slide right in front of me, but it doesn't sound like he was re-challenged for his statin, because it sounds like he does have statin-associated muscle soreness, SAMS, but we really want to stop it and see if it goes away and then re-challenge him. But my feeling is he probably will not be tolerating that. So I would think about that, and then start thinking about a non-statin. I would also do additional blood work too. Certainly check a thyroid. I don't think that's what's going on, but it can promote muscle soreness. I would check the LP(a) as well. So those are the things that I'm thinking of. And Dr. Wong, any thoughts?
Yeah, so certainly, as far as his LDL is concerned, right, our U.S. recommendations based on the expert consensus decision pathway I just showed would probably definitely want him under 55, right? But we have to realize again that he's a man of Asian Indian ancestry. So do we want to be more proactive and maybe be more in line with what the Lipid Association of India recommends for this person, which would be around 30 milligram per deciliter or less? Certainly, it wouldn't be within guidelines to continue to actually discontinue his current statin, right? He's able to tolerate what he's on right now. But I agree, he may, and we may see from the next slide what happens to that, and you wouldn't, but you wouldn't want to discontinue it, but you could add a PCSK9 inhibitor. Certainly, that's going to give him another 50% LDL cholesterol reduction. You probably wouldn't want to just have ezetimibe as monotherapy. That's not going to do enough for his LDL. And of course, you'd want to do, additional blood work. I concur with the rest of you. We'd certainly want to get an Lp(a) measured. We know that tends to be elevated Lpa tends to be more common in individuals of Asian Indian ancestry, for example. And so I think, those are my comments, at least at this point.
I would just add again, the 2018 AHA-ACC cholesterol guidelines say in high-risk patient LDL less than 70. And I know we're talking about endocrine society guidelines of extreme risk and now introducing Indian guidelines, but less than 70, certainly with an option to go less than 55, based on an extreme risk diabetic state. So just for the audience out there, different guidelines, different organizations. So just to make everybody aware of what we have. So Dr. Wang, why don't we go on to the next slide, because there's some clinical information coming up.
Sounds good.
Here we go.
As previously mentioned, we did more lives, and eventually he had to get off statin because of worsening muscle pain. So here's vitamin D, TSH, CK, and CMP as well. His lipoprotein(a) was 235, and that's obviously elevated. So given these labs and the current clinical scenario, what is your next step in managing this patient's lipids? Vitamin D and with a new statin such as rosuvastatin, PCSK9 inhibitor, because is not a goal for the LDL, or give them a trial of diet and exercise, and to maybe consider a niacin to lower LP(a).
Okay,
Well,
so good, Merle.
make some comments here. I mean, certainly we want to keep a statin on for the pleiotropic or the non-LDL lowering benefits if he would tolerate it. Just to note, to get some on board, you could do one of the newer statins that have a longer half-life, such as rosuvastatin, 5 milligrams Monday, Wednesday, Friday. So I would consider that. I would not do the vitamin D supplement. I would not use niacin. I certainly would check the diet and exercise as well, send him off for nutrition counseling. So I would really focus in on the second choice there, either adding a PCSK9 inhibitor or one of the other more potent, newer non-statin medications. I think we really all are in agreement that we want to get his LDL down very low. So Nathan, any thoughts from you?
Yeah, no, I completely agree with you. I think the only thing that I would add, you would definitely want to try, another statin such as rosuvastatin. Of course, it's going to need more LDL lowering. So concurrently, if possible, you could even add a PCSK9 inhibitor. I think one of the important points to make here is, this person recently had an acute coronary syndrome, right? So he's at great risk of subsequent events. So we really want to try to get that LDL down as fast as we can, right? So that would, and it's likely, he would qualify for a PCSK9 inhibitor, in part because his LP(a) is elevated, right? And you're going to get about 25% or so LP(a) reduction from a PCSK9 inhibitor, even though, as we know, they're not specifically indicated for lowering of Lp(a), but they do have that benefit, and they're more likely to get reimbursed in such an individual with elevated Lp(a).
Right. So good. So I know in the slides coming up, we're going to talk more about the Lp(a) and medications that are currently available and those that are in development. But so let's go on.
All right. So what we ended up doing was that we prescribed rosuvastatin 10 and Repatha or evolocumab, 140 milligram every 2 weeks. And patient comes back after 3 months, and the new lab shows LDL 95 this time. And unfortunately, he forgets, to do the injection sometimes, and he doesn't like it. So what would be your best option? So would you increase the statin, or would you replace the Repatha with either inclisiran or ezetimibe?
I think the first thing you want to do, you need to push down the LDL. So given the ezetimibe gives you about 18 to 20% reduction in your LDL, that would be a no-brainer to add. And then the question comes down is how can we improve his compliance with his evolocumab injections? And then, of course, choice 3 is, would you be able to get him inclisiran to replace his evolocumab in terms of efficacy and whatever insurance coverage you'd have. So I would certainly add ezetimibe, and you'd get yourself down, another 20%. So you're basically still not below 70 and nowhere near 55.
Yeah,
So
but I think, you're going to need more LDL lowering, right? So if he's not able to adhere to evolocumab, then perhaps inclisiran might be a good option. Maybe we can go to slide, let's see which one, slide 14. Does that work? Going to slide 14. So what's interesting, these are some recently published real world data that shows us that there's quite a drop off in PCSK9 monoclonal antibody use after 6 months, right? Only around 60% are actually adherent. A number of people discontinue, and it would be interesting to examine why that's the case. Whether because it requires them to self-inject themselves, right? So there's a lot of patient factors here at stake, whereas if you have to go into the clinic or an injection center, and have a healthcare provider, inject you, then perhaps adherence is a little bit better. If we go to the next slide, slide 15, this Komodo study that was presented not too long ago, I believe at AHA, in November, shows what they did here is that they actually compared claims data to look at adherence for patients who newly initiated inclisiran compared to the PCSK9 monoclonal antibody therapies, and they are showing after 6 months greater adherence at around 70% for inclisiran versus closer to 50% for the PCSK9 inhibitors. So there is at least some early data that people may be more adherent. So this may be an option. Of course, we are anxiously awaiting the outcomes data from Victorian-2 Prevent, right? So while the PCSK9 monoclonal antibodies have outcomes data that were published both from Fourier and from Odyssey Outcomes and show a 15% risk reduction. We don't yet have that answer for inclisiran. So that's going to be important to see moving forward.
Right. So I think that's a very good point. I think with the inclisiran, as we know, after the initial injections, it's twice yearly given by a healthcare provider. So if adherence is an issue, especially he doesn't like being injected, that would address that. The inclisiran will lower the Lp(a) as well. So I think that certainly, thank you for this data showing that. And I believe in 2026, we'll see some of that cardiovascular outcome data for inclisiran. So I did see a question pop up about the high sensitive CRP done for this patient. So, we know that measuring that is an indicator of risk in many of the guidelines. I think for this patient, it wouldn't change my plan. He has already put himself into the very high risk category, and I don't think there could be anything else that could incrementally make him even higher.
I might just make the comment, I'm just trying to see what his CRP was here, but he could potentially benefit additionally from low dose colchicine, right? So low dose colchicine was recently FDA approved for cardiovascular event reduction in patients. Really a wide range of patients, both primary and secondary prevention patients, but the data are really from the Lodoco trials in particular that were done in post-MI patients, similar to our patient. So if we're trying to reduce residual risk, which is very high in such patients, and those trials were done irrespective of knowing the C-reactive protein, that may be an additional way to reduce their residual risk.
I think that's also a great point. But first, I think we need to lower this patient's cholesterol risk and other risk factors associated with it. And then down the road, look at if his high sensitivity CRP is greater than 2.0, which would put him at increased residual risk, and colchicine in the form of 0.5 milligrams. So that's prescription colchicine for cardiovascular risk reduction, not 0.6, 0.5 daily, may be useful for patients such as this. But there are certainly many other risk factors in his case, from continued smoking to his diabetes to his hypertension, and other interventions that we can certainly talk about. Okay, I think, why don't we go back to the last slide of the case where we were before?
All right, so okay, so I'll go ahead and some closing thoughts on this one. So patient remains on and tolerates rosuvastatin 10, fortunately, and he got started on inclisiran as well. So 3 months later, returns after 4 months, shows an LDL of 50. Yeah, actually 4 months. So at this time, anything else that you would do? Do you think that LDL should be even lower than this? How about diabetes? How about his Lp(a)? What do you think about other therapies that are emerging for Lp(a)?
So I think, Nathan, do you want to talk about improving his diabetic state, or Merle, do you think his LDL should go lower at this point?
Okay, I'll tell you what, Nathan, why don't you start off and then I'll add my comments as well.
Yeah, well, I already commented about the LDL issue based on this patient being an Asian Indian man, but so I'll let Merle discuss that further. But as far as diabetes, we have to not forget that irrespective, even though the patient's A1C is controlled, irrespective of the A1C, there are newer therapies. And if we can go to slide 16, it's important that we recognize, that in patients with ASCVD who have diabetes, right, which is this patient, you can consider a GLP-1 receptor agonists will tend to have more anti-atherosclerotic effects versus a SGLT2, more heart failure effects, so heart failure prevention effects. So certainly, if this patient already had heart failure, you would definitely want to go with the SGLT2 first, but you could certainly consider the GLP-1. And remember, we have data from the SELECT trial, even though SELECT was not in patients with diabetes, but patients with ASCVD, that tends to support the risk reduction benefit. And certainly the diabetes trials, I should say, right, such as SUSTAIN 6, as well as LEADER, right? So patients who have ASCVD and diabetes do definitely benefit from these therapies. And, so we have to, the cardiology community needs to better embrace these. Certainly they've embraced SGLT2s for heart failure, but we need to be thinking about all these therapies that may have cardiovascular as well as now kidney benefit, and I mentioned already the heart failure benefit. Even there's new data as to GLP-1 receptor agonists and how they may benefit heart failure with preserved ejection fraction in particular. So very exciting area.
Right. So what I would add to that about his LDL goal. So yes, I would still try to get him down lower. Remember from the PCSK9 monoclonal antibody trials, we showed that an LDL of 25 was safe, especially with the guidelines that Dr. Wang shared with us for Southeast Asians, lower would be better. In terms of the Lp(a), I would expect that we have some lowering with the inclisiran, although it was quite high. And remember, we still don't have goals for, Lp(a) may become a target of treatment with goals. The two Lp(a) lowering drugs that I believe are both in phase 3 trials now, pelacarsen and olezarsen, are not out yet, but certainly have that on the horizon for him. So I think that we're making good progress with his lipids. I would continue to be very aggressive. You could check in Lp(a) again and see where we're at.
Yeah, and I think, as far as the Lp(a), remember since we don't have approved therapies, with the exception of lipoprotein apheresis, which will, of course, instantly lower Lp(a), but of course you have to give that every 2 weeks, and it's only indicated for certain high risk patients, particularly with FH who have uncontrolled LDL and elevated Lp(a). But if so, the overall focus, right, is on lowering this patient's global risk, right? That's what our guidelines recommend. So better controlling the hypertension, better controlling the diabetes, lifestyle management, right? So we have to focus on that. But if we go to slide 17 briefly, this kind of summarizes what's in development, and what Dr. Myerson had mentioned is we're anxiously awaiting the results from the cardiovascular outcomes trials involving pelacarsen and olpasiran that will be read out in the next few years. And then there are several others as shown here. I'm not going to read it all for sake of time. You can read it faster than I can say it, that are in development and very promising, even an oral PCSK9 molecule, and gene editing approaches may be still several years or more away, but perhaps 10 or 15 years from now, maybe we will have a one injection gene editing approach to permanently lower Lp(a). So very exciting therapeutics in this space.
I think, Nathan, you made a good point. Currently, the FDA does approve lipid apheresis for LPA in the setting of FH, CAD, and PAD. So short of that, appreciating the fact that LPA can accelerate atherosclerosis, we need to look at the benefit from PCSK9 and inclisiran therapy, getting you the 20 to 30% reduction on that side until these agents are available for us. And as we highlighted, this patient has multiple other risk factors, particularly continuing smoking, which is an area we all fall short of. And I know at our institution, we have a very good smoking cessation program where the group reaches out to the patient and really coaches them through. So many other things we could do to help this patient until these therapeutics are available at the end of phase 3 trials. So, all right, so can we go back to the case? Do we have anything more on the case before we go to the second case? Okay. And I think there was one question I'll ask Merle and then Nathan. With the PCSK9 studies, particularly the Fourier trial, getting LDL less than 25 was beneficial. With event reduction, are you concerned about LDL going too low? And the question asked about more muscle tears, tendon ruptures with extremely low LDL, but probably better. Another question would be, cognitive effects or too low LDL affecting the brain. So,
well, I should say my thought would be I would have switched him over to measuring ApoB because first of all, you don't have to be fasting for it. There's some discordance, especially people with metabolic disease such as diabetes, where the LDL might be lower, but the ApoB is discordant. So I would have done that. It probably also is much more accurate at the lower levels of the LDL, which, as you know, is calculated. So I would do that. But to answer the question, I would not be concerned. The PCSK9 trials did show very low LDLs were safe. So that I would continue being very aggressive. I would follow the ApoB. And I have not had a problem with muscle tears, tendon ruptures with extremely low LDL or with statin use. So Nathan, do you want to go over the cognitive and some of the other concerns?
Yeah, no, completely agree with you. And, I think we have to remind ourselves that several guidelines, including from the National Lipid Association and ACC/AHA, have recommended that non-HDL cholesterol, right? You don't need to be fasting it. You just calculate it from the basic lipid profile, should always be considered as a secondary target. But as far as the low LDL issue, we have to remember that there were over 500 patients in Fourier that got to an LDL of even below 10 milligram per deciliter and showed further added benefit. And in fact, Fourier, as well as the Glagov intravascular ultrasound study involving ivolocumab, showed that there was no lower threshold below which there was no further benefit. You continued to get a benefit at least down to around 20 milligram per deciliter. And they did not see a threshold where the benefit flattened out, whether it was for cardiovascular events or from from reversal of atherosclerosis. And then as far as the cognitive issues, it was absolutely, impressive how Fourier had a sub-study that was called the Ebbinghaus study, right? And they had objective measures from what they called a spatial working index of looking at cognitive function before and after therapy, and they saw no harm from the subset of Fourier that was enrolled into Ebbinghaus. So at least from the data we have, and certainly granted, we don't have 10 or 20 years of follow-up data, so we need longer term data on cognitive safety issues, but at least from the data we have, there seem to be absolutely no signals of any concerns.
Okay, great. There were one or two questions about, again, muscle tears, tendon ruptures, one involving rosuvastatin. I don't see that at all. And I think, people may be, referring to bempedoic acid, where certain subgroups, when using bempedoic acid, may be at an increased risk for tendon ruptures. So that may be, where some of the questions coming from. But I personally have not seen any increased risk of any muscle tears or tendon effects with statin therapy. So I know we'll talk more about bempedoic acid, a little further on. So keep that question in the back. All right, so Dr. Wang, do you want to go on with the case presentations?
All right, so let's
Okay.
move on to the next one. So yeah, this is a primary prevention case, and just FYI for the audiences, these cases are adopted from National Lipid Association Teach ASCV program. So, okay, so we have a 54-year-old Black female here presenting to the clinic for routine care, concerned about cardiovascular and metabolic health. She's obviously postmenopausal. Blood pressure is elevated, and she's a smoker, and BMI is 32. That's she's obesity range, and there's a history of preeclampsia. Otherwise, she's healthy and not on antihypertensives or lipid-lowering therapies. Occasional non-exertional chest tightness, but also there's shortness of breath with moderate exertion. Mother had aortic valve replacement at 48. With hyperlipidemia, but don't know much otherwise. Maternal uncle had an MI at age 40. Next slide. A remarkable exam, other than this 2 out of 6 systolic murmur at the left sternal border, no bruise on the carotid. Second heart sound is audible. Physically inactive. Frequently eats fast food, fried foods, and meat with minimal vegetables and fruits. Renal function, TSH, and liver function tests were normal, and other labs were also normal. UA was normal as well. And next slide. Here are her recent labs, including the HSCRP and the lipid profile with the LP(a), as you can see. And next slide. So first question, what is the most likely diagnosis? We have mixed hyperlipidemia, FH, elevated LPA, or no diagnosis of hyperlipidemia.
So,
Well, I would say elevated elevated LP(a) is primary diagnosis here.
Yeah, I'm thinking that, we don't have new terminology for the mixed hyperlipidemias that include LP(a), but certainly her LDL is too high as well. And she has several risk factors, but the LP(a) is quite elevated. So it's a mixed hyperlipidemia and elevated LP(a).
Yeah, then we'll
Yeah,
throw out
both
elevated
both are
C-reactive
one.
protein for her inflammation. So let's move on to the next slide so we can get through the case.
Okay, so what would you recommend further? So calculate the ASCVD score and discuss treatment approach and evaluate for other possible risk factors, genetic testing for LPA, or perform stress tests, or perhaps echo or cascade screening for relatives of first and second degree.
Well, I think from a risk scoring, certainly it's always good to do it and show it to the patient. She has many risk enhancers as well. I would say that off the bat, she's already at higher risk and certainly want to get started with lifestyle modification as well as pharmacologic therapy.
Yeah, and her mother, I think it was, right, had a history of aortic valve replacement. So considering that she has a high LP(a), one could certainly do an echocardiogram to possibly screen for aortic disease. And yeah, certainly cascade screening. We don't typically, the question about genetic testing, it might maybe help motivate the patient or the doctor to do more, but technically it shouldn't change your treatment approach, right? You're going to treat the patient the same way on the basis of their elevated LP(a), regardless of whether or not they have a positive genetic test. So those are kind of my thoughts.
Right. Now, I have to go back to the previous slide to see if she was symptomatic, if she does any physical exercise, but certainly, if she is sedentary, you would know if could she be having angina or an anginal equivalent, but I would want to tease that out. And if there was suggestion she was symptomatic, I certainly would do a stress test for her.
All right. Would anyone do a calcium score?
Well,
Yeah.
we can.
Go ahead, Nathan.
Okay, well, maybe you can go to slide 28. As it's a good point, right? So this patient is an intermediate risk patient, right? Who has multiple risk enhancing factors, right? Preeclampsia, elevated LP(a), elevated hsCRP as well. So it should be a pretty clear decision to at least consider moderate intensity statin therapy. I think many of us would say, high intensity statin. So, at least on the basis of these 2018 guidelines, right, we would have enough information, at least in many of our opinions, to start treatment. But certainly having a calcium score could further motivate the patient. We published data and others going back some almost 30 years, 25 years or so, that shows, having a positive calcium scan is more likely to get patients to take their cholesterol-lowering medicine, follow a healthier diet, lose weight, and control risk factors in general.
I think that's a good answer. And I think, many of us would agree that we don't need the calcium score to help us move along whether the patient needs treatment or not. And I think it's great that you also highlighted the elevated C-reactive protein as a risk enhancing feature as well. All right, I'm trying to field some questions here from the audience for us, but let's go back to the case and see what the next slide is. And I threw in some other questions for Nathan and Merle. All right, let's see. All right, good.
Next one.
Okay.
So we can
So
pick that up where we left off.
Yeah, how would you treat the patient? Sure.
Yep. So how you treat it, refer to dietitian, and for dietary modifications, statin, niacin, and again PCSK9 inhibitors or other risk factors, try to modify them.
So here's a thought-provoking question for you, Merle. If you felt the need to do the calcium score and it came back 0, would you not treat this patient despite the multiple risk factors?
Yeah, so I would not have done the coronary calcium. I mean, if she asked for it, if she said that will make the decision. So a 0 would not change my plan for aggressive management for her. She's also relatively young, and presence of calcium is very strongly related to age. Plus, there is research showing that even with a score of 0, you can still have blockages in your arteries. You are still at high risk. So remember, calcium is a surrogate marker more so than an actual measure of coronary atherosclerosis. So, right, I wouldn't. I think that she will need a statin, definitely. I think that it may or may not get her to goal. I think addressing the other risk factors as well. So, Nathan, any thoughts on what you would do?
Yeah, no, and I would I would add to your comment about the calcium score. One of the things we have to realize is that African American people tend to have lower calcium scores than other ethnic groups, right? Particularly whites. And so, and they tend to have more hypertensive heart disease too, right? So trying to, you could have, as you pointed out, the issue of, a 0 calcium score, but the patient could still have atherosclerosis or be at other risk. And I think, as discussed earlier, right, we have enough information that most of us would want to give a statin. Certainly, we'd want to refer her to a registered dietitian, and that raises a comment that I make all the time that, we need to better utilize our dietitian resources through the Academy of Nutrition and Dietetics, and very few healthcare providers know about that organization. So just putting in a plug for that. And, of course, niacin is not really on the table anymore to reduce risk. PCSK9 monoclonal antibody therapy, it may be hard to get it approved in a primary prevention patient. So you probably want to at least start with a statin. I think that's pretty clear.
Right.
Good.
Yes.
And so I think, and we'll move along a little bit, but before we get to this patient that maybe not be able to tolerate a statin and our options, just 1 or 2 loose questions in there about FH screening. Many of the genetic companies will screen family members for free if the initial member is positive for elevated LPA or FH. So you can look into your various genetic testing laboratories for that. It can be facilitated in private practice. You have to document that you had that discussion and then offer the patient that opportunity. And usually the genetic lab will contact the patient. Another question about, would you start out with a CCTA screen for patient? I don't think that would be easily obtained in terms of prior authorization, and using dietitians as the foundation for what we do, as Nathan highlighted. But moving along, Nathan, I know this patient is very difficult. We try to start him on statin therapy and she was unable to tolerate statins. So what other therapeutic agent do we have available, and maybe want to review some of the data in the last few minutes?
Yeah, well, so we can go to slide 29. I think certainly the, latest development, right, is a row of bempedoic acid, right, which was tested in statin intolerant patients in the Clear Outcomes trial. And let's go to slide 30, the next slide. And overall, it showed a 13% risk reduction in the primary outcome. When I was watching this live at ACC, I believe it was, I whispered to the people next to me and said, I predict there's going to be a 15% relative risk reduction. So I was partly right, because the 3-component MACE was a 15% relative risk reduction. But very importantly, if we go to the next slide, 31, that's the last background slide, I promise. The primary prevention subset had an even greater benefit, right? So remember, this is a primary prevention patient, and look at that, a 30% risk reduction, right? Hazard ratio of 0.7 for every 43 patients like this that you treat. You could prevent a cardiovascular event. So very, very promising data. This was published in a subsequent publication from the Clear Outcomes group. So, you know, I think that's certainly an option. Obviously, there remains some access issues, which perhaps the others could speak on, but you know, this is a very important therapy that I think needs to be on everybody's radar screen for patients who either are, you know, statin, at least partially statin intolerant or fully statin intolerant, or in general need further LDL lowering than existing therapies, because this is really the only non-statin that has cardiovascular risk reduction evidence in the primary prevention setting. You know, we have to remember that ezetimibe from the IMPROVE-IT trial was tested in a very high risk ACS population. But here we have now an option in primary prevention for further LDL reduction and cardiovascular event reduction beyond statins.
Right. So
That
I
was
think
great.
we're going to wrap up in just a minute or two. I agree. I think this is a case where reaching for the bempedoic acid would be very helpful, especially with the new cardiovascular data that we have.
And in the last few seconds, again, tendon rupture occurred in only 0.5% of patients that were on bempedoic acid and were associated with the group that had history of tendon injuries or were on quinolones, or they had renal failure. So there are other caveats associated with that. So with that, you know, I want to thank Dr. Wang for presenting an excellent pair of cases, and Dr. Wong for his input, and Dr. Myerson for her input. And as always, we invite you to come back every last Tuesday of the month. The last Tuesday of the month is Lipid Panel. And if anyone wants to present, participate, please email Mandy. And on behalf of Merle and myself and Dr. Wang and Dr. Wong, we thank you for joining us tonight, and hope to see some of you at the NLA meeting in Las Vegas later this week. So thank you very much.
Thank you all. Take care.
Thank you. Thank you. Good
Thank
night.
you.